Good evening, everyone. Welcome to my YouTube channel, Pain Free Partha, and my website, www.painfreepartha.com, for free downloadable slides, which can be editable and presented by you. Everything is free. So today we are going to talk on tele anesthesia. So now imagine a patient in a rural hospital develops severe hypotension. They're not doing major surgeries. For example, a PDA closure. There is no cardiac anesthetist available. Can an expert sitting in Chennai save the situation, save the patient, and save the patient from hypotension? Suggest ideas to get hypotension. This is what is called teleanesthesia. Now, teleanesthesia is a delivery or supervision of anesthesia care from a distant location through video conferencing. We have an internet, patient monitors, telecommunication systems. All these things make what is teleanesthesia. Now, what about in intraoperative or a perioperative setup? It can be used for preoperative assessment, intraoperative supervision, and a postoperative follow-up. All three things of perioperative care we can do under teleanesthesia. Now we have a trainee pilot isn't flying in a craft in Pondicherry. A senior pilot is sitting in the control in Chennai. He can see the aircraft speed, altitude, fuel level, weather data in real time. Now through audio and video, he guides the trainee pilot during takeoff and landing. So anything happens, he advises immediate corrective action. Now the other pilot, the senior pilot, is not in the aircraft. That is a major difference between other things. The senior pilot is presently not in the aircraft. The senior pilot is not physically inside the aircraft. That is what is teleanesthesia. The concerned anesthetist may not be with the patient. He remotely monitors, suggests changes, and corrects the problem. Now, there is a big definition of telemedicine by WHO. It is a delivery of healthcare where distance is a critical factor. Information and technologies. You have a valid information, it may be useful for treatment and prevention of diseases. It may be used for continuing education also, advancing the health of individuals. Yes, we can prevent diseases, we can treat diseases, we can give continuing education, but the main person is distant from the scene. Now we think all these things, telemedicine, all these things after Corona now. It is in 1967, Massachusetts General Hospital, before the advent of all these things, where computer, internet, all these things, they used to communicate with airport officials. Now we have two types of telemedicine. One is real-time synchronous, and second is store and forward, which is asynchronous. I'll tell you what is what. Now, real-time synchronous means devices such as teletestoscopes or teleautoscopes. And he goes a remote expert and sees the patient and hears the sound. Everything is live, real time. Now I had this stethoscope, and I don't want to mention the name of the company. What happened is now I don't go to the clinic sometimes in Corona period. So that time the stethoscope is put there, and by the way of here I can hear there, and this is linked to the next room or the next room, or sometimes this is asynchronous. Or the clinic girl picks up the sound in the WhatsApp for 1 minute, audio voice, and then WhatsApp me, and I will hear. So this is asynchronous because this is not happening in real time. So medical data are stored. For example, a preoperative ECG and echo is sent, and the fellow tells, no, 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 don't do this. Do a coronary angiogram and do this. This is what is called store and forward or asynchronous. So we need Sanjeevani software. Why we need is there are not softwares, not any business type of this thing. This is government approved. And anesthetist discuss the patient fitness over a video call. Now, everything can be a software. Patient's ECG, blood test, everything we need not loaded. He gives us thing and the electronic data automatically goes to the telemedicine specialist. That is what is software is all about. Patients can undergo PAC from their home or a nearby health center through the video consultation. Now the patient is in a PHC, government PHC. He's going to have a hernia done. Yes, he goes and discusses with a nearby medical college, Tanjore Medical College, and he says back is okay and fine. So teleback is fine. Virtual airway assessment is possible, and he has avoided an 100 to 150-kilometer travel. Review of medical reports, previous prescriptions, investigations, X-rays, EGGs, ultrasound, echoes, everything. Now, a 50-year-old example I will tell you. A diabetic or hypertensive woman is scheduled for lap hysterectomy. Uploads her ECG, echo, blood investigation, current medication. And telepath tells dapagliflozin withdraw for 2 days. And comorbidities optimize, start insulin, and get the sugar below 240. This is what is called the ideal telepath. Virtual airway assessment, mouth opening, is malnumbity grading, neck movements, environmental distance, all can be assessed by video cameras. I will come back to the deficiencies later. Early optimization of comorbidities. Okay, hypertension, diabetes, all this will come down if you have telework and then come to the hospital. Patient education, fasting instructions, medication advices, anesthesia risks. What are the expectations perioperatively? Can be explained easily remotely. For example, you will come there to the room and you will have an IV line, some sedation, and then you'll be like this, and then all these things can be clearly explained by a remote back consultant. Now, what happens if you do this? Last minute cancellation, last minute postponement is avoided. For example, the anesthesiologist notices a hemoglobin of 8. Don't admit now. No, it will get cancelled. Give blood or get the hemoglobin up. So there is a high patient satisfaction, saves time, travel costs, waiting periods. Everything is same, but quality of care is maintained. For example, a 30-year-old software engineer, he was about to do arthroscopic knee surgery in Bengaluru, but planned surgery in Chennai. Instead of taking leave for a preoperative sit, come to Chennai, go to pack, all these things, he completes the telepack to the hospital. He reviews his investigations, answers his questions, and the patient save time, avoids travel. More importantly, no leave is obtained. Highly convenient experience. Is during complex surgeries when a specialist is, for example, CABG hospital in Kumbakonam, develops severe hypotension. We can have a video conferencing with a cardiac anesthetist in Chennai. The experts lives the monitor data, discusses the fluid and vasopressors. I used to do like that. When I put the tube or something happens, BP falls, I call upon my student who has become a cardiac anesthetist now. I call upon Arjun or somebody and I ask him to what is it to be done like. So he sees the live monitor data. He sees the vasopressors management. This is real time, synchronous. Real-time monitoring of ECG, blood pressure, now arrhythmias, he can easily rise. ETCO2 rises, he can tell. Exhausted soda. For example, all these things can be suggested from a remote or distant center. Now this is about preoperatively and intraoperatively. He can also tell about remote supervision of anesthesia providers, guidance during difficult, unexpected airway, unexpected major blood loss, even closed room drug administration, anesthetic infusion. Teletherapeutic drug administration by long term, there are a lot of studies like this. So, for example, if you close to propofol is started and that fellow operates from there, unexpected difficult laryngoscopy. Now he gates there. We put the video gate bougie and successfully intubates. Now, in critical care, a remote specialist of ICU patients. He is an urinary tract infection. BP is 80/60. He is a diabetic with a jaundice. He goes, all things are down by an ICU specialist. Reduces travel treatment costs, remote ICU monitoring. Also, I get better. No, I sometimes talk to the Apollo consultant or somebody consultant. This is not about any recommendation for anything like that. No advertisement. I just tell my friend is there in Apollo, and I call him. They say, "Okay, boss, this is what is the problem now." He tells, "Stop clindamycin and start ticlopenine," something like that, because this is what is needed in this case. Inadequate telecommunication, bandwidth is not there, poor connectivity in rural areas, the money is not there, licensing and regulatory restrictions. Because that hospital is okay for telemedicine, our hospital is okay for telemedicine. All these things has to be done. Cannot perform physical examination. Airway assessment may be imperfect. That's what I told. One number T may be slightly wrong because if you are doing a virtual airway assessment, there may be privacy concerns. There may be medical legal issues because this person has done fit from there. So you can also do in the post-operative teleanesthesia, remote post-operative pain assessment, management, monitoring recovery and complications. You know what happened once? I was called by video call. This patient has not woken up. I told your patient is breathing and you reversed, but you are not switching off your sevoflurane. Sevoflurane was 1%. Then the switching of the sevoflurane, patient got. So this is a simple example of polyanesthesia. Pain assessment and management. A total knee replacement patient reports pain score, pain scores. Start terminal, start out. Whereas post-operative nausea. Breathing exercises, how to do during a rehabilitation support. All these things are possible with teleanesthesia. There is also the role of teleanesthesia in chronic pain. Beneficial for elderly patients, those with mobility issues. For example, this fellow has got difficulty, got operated for total hip replacement. He cannot move. Now he goes on to a video call and goes there. He tells that you do like this, you do like this, you take tramadol tablet, all these things. So it is very easy to do monitoring and physical exercise, teaching, lifestyle modifications for a remote who has got operated in the hip. Now, which of the following is an example of store and forward, video consultation, telephonic call, sending ECG for later review, remote robotic? Now, C is the example because store and forward are asynchronous. Yes, available in India, telepack clinics for remote, ICU monitoring, tele-mentoring during difficult cases, emerging AI assisted monitoring. These all expanding role after Corona. Yes, available in India. Now we have got telemedicine practice guidelines 2020. Patient consent is required because your privacy is gone. Your data is uploaded and he is from that hospital. Teleanesthesia, preoperative, intraoperative, and postoperative. But it is not a replacement for bedside anesthetist. So he can suggest, but we have to see. There is 1 month certified course of CDAC. Thank you all for this patient listening. Welcome to my YouTube channel. Subscribe and listen to my YouTube channel, Pain Free Partha.